Hello, my name is Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. And you can also visit GPnotebook.com for podcast episode show notes and to find out more about the upcoming study group meetings which occur all year round. Now in this episode, I want to discuss Hidradenitis suppurativa, or HS, to make it easier, as this is a condition that I think is often under-recognised and often undertreated, and it's a chronic inflammatory dermatosis that typically affects areas of pilosebaceous gland-containing skin. It occurs in the epicrine follicles of the skin, and so it typically affects the groin and axillae, as well as other sites such as the breasts and perineum. And the occlusion of these skin follicles can then in turn lead to chronic relapsing inflammation, discharge and progressive scarring. And unfortunately, if we don't treat this adequately, we can get induration, ulceration or fistula formation. Now, I think it's important to remind us that it is not an infectious disease as such, but it's the bacterial propagation in occluded hair follicles that actually triggers immune activation. We then get inflammation, and it's that results in the pus formation and tissue destruction and even scarring that we sometimes see. Now, you might not be surprised to know that patients with HS frequently have coexisting conditions such as type 2 diabetes and metabolic syndrome, but also inflammatory bowel disease, and also there's a link with depression. Now, the typical age of diagnosis is from late teens, 17 to 18, to just under 30, but onset may occur soon after puberty in some patients, with an average age of onset of 21. And we've got a European prevalence that's been estimated to be in the region of about 1%, so it is not insignificant. It does occur more commonly in females, with a female to male ratio of about 3:1. Now, there are a number of significant risk factors, including genetics, with a family history being present in about 1 in 3 cases. Somewhat surprisingly, cigarette smoking is a risk factor, as is obesity, lithium therapy, hormonal factors, and the conditions I mentioned such as diabetes, inflammatory bowel disease, and polycystic ovary syndrome. Now, the classification of HS is often done using the Hurley classification, and this is the most frequently used classification type within general practice, and it is helpful, I think, in guiding our treatment choices. And we've got stage 1, 2 and 3. So Hurley stage 1 is mild, stage 2 is moderate, and stage 3 is severe. So stage 1 is the presence of abscesses and nodules that are inflammatory, but without any scarring. Stage 2, or moderate Hurley stage 2, is the presence of abscesses and inflammatory nodules with scarring. However, the lesions and the scars are separated by areas of normal skin. In stage 3, or the severe Hurley stage, there is extensive interconnected scarring with or without active inflamed lesions. Now, there's no specific confirmatory test available yet for HS. It's a clinical diagnosis, and the diagnosis requires recurrent, painful or suppurating lesions in the characteristic skin distribution that have flared up at least twice in a 6-month period. Early lesions are solitary and painful and pruritic, and these may persist for a few weeks or months and then develop into pustules, which rupture with discharge of purulent material, and this can be distressing for the patient. We then get healing, often with dense fibrosis and sometimes scarring. And recurrences tend to occur in the same region, and this is why chronic sinus formation can occur in these regions. Now, although the diagnosis is classically made on clinical grounds alone, I sometimes do investigations. I sometimes do a full blood count to identify any underlying anemia. I always do blood glucose levels to exclude diabetes, but I don't often do microbiology swabs because these are usually negative. I only do them if I think there is an active infection present. Now, skin biopsies aren't usually required, but in patients with long-standing hidradenitis, you can sometimes do these to exclude squamous cell carcinoma and to differentiate from other inflammatory diseases linked to this, including Crohn's disease. Now, squamous cell carcinoma may actually be a consequence of long-standing chronic inflammation in advanced hidradenitis that has been present for many years. If we look at the management of HS, this should always be multidisciplinary, and I'm talking about lifestyle advice, medical treatments, and occasionally surgical treatment. And I would recommend early referral to a dermatologist if your patient doesn't respond to 1 to 2 courses of long-term, by which I mean 3 months, of antibiotics. And medical therapies we can use include things like topical and oral antibiotics, retinoids, and in moderate to severe disease, biological agents. So the lifestyle advice I would normally give to a patient with HS would include hygiene advice on using non-soap cleansers and non-fragranced simple antiperspirants, wearing loose-fitting clothing, and if possible, sweating, skin trauma and friction, and skin irritation should be avoided. Now, many patients with HS are both smokers and obese, and we know that obesity is an independent risk factor for the development of HS as well as contributing to its severity. So all patients should be advised to stop smoking and to lose weight if obese. We mustn't forget the psychological impact of HS too, so always assess this, including checking for poor self-image and depression, using a PHQ-9 score if necessary. If we look at the medical management, a very short course of systemic corticosteroids may be beneficial, such as oral prednisolone, 30 milligrams a day for 3 to 4 days only, and for patients with early stage 1, antibiotics are a good first-line treatment. For chronic and relapsing stages, evidence-based treatment options includes a topical antibiotic, such as clindamycin 2%, used topically twice daily for 3 months in mild disease. Systemic antibiotic options include limacycline 408 milligrams once daily, tetracycline 500 milligrams BD, doxycycline 100 milligrams daily, or erythromycin 500 milligrams BD. Now, if you've used these for 3 months and they're not effective, then clindamycin 300 milligrams BD, sometimes in combination with rifampicin 300 milligrams BD, may be used. In severe cases, anti-TNF therapies have been shown to be effective, and NICE have approved adalimumab and secukinumab for treating moderate to severe HS. Some North American guidelines have suggested that hormonal agents, including spironolactone, might be considered in women who have clear premenstrual flares of HS, but this should be limited to women who are practicing adequate birth control, and in fact, UK guidelines currently state there's insufficient evidence now to recommend anti-androgens in the treatment of HS. You can use dapsone, but this should only be reserved for patients with moderate disease if they've failed multiple courses of combination antibiotics. And I have to say, the evidence for its use in HS is limited, and there is often rapid disease recurrence once it's stopped. If we think about retinoids, such as isotretinoin and acitretin, then these have demonstrated moderate efficacy in HS, and treatment durations in excess of 6 months have been reported. But always remember, these medications are potentially teratogenic, and we must avoid them in women of childbearing potential. You can also consider using cyclosporin. The biological agents I mentioned, such as adalimumab, this is the approved biologic for HS, and it's now considered the first choice biological agent in treating moderate or severe HS that's refractory to all other conventional treatments. And secukinumab can only be used if adalimumab isn't suitable, not working, or has stopped working. Finally, if we look at surgery, then it's important to remember that simple incision and drainage of painful boils is not typically effective in HS, as over half tend to recur, although local excision is possible for quiescent, small lesions where the clinical margins can be clearly defined. But if we're looking at surgery, then wide excision with wide and deep margins is the current standard of care for surgical therapy, and referral to plastic surgeons and or a dermatological surgeon is always advisable. When we think about the prognosis of HS, well, the natural cause of mild HS can be benign and adequately controlled with relatively simple medication. Limited moderate disease requires more aggressive and possibly surgical therapy for adequate control, and poorly controlled moderate disease can rapidly progress to more severe disease. Now, it should be remembered that complete remission from symptoms is usually unlikely with purely medical therapy alone. And I would make the point again, patients with long-standing severe HS are more likely to develop SCCs, particularly in the perianal and inguinal areas, and this occurs more often in men, with the average duration of symptomatic HS patients going on to develop an SCC being around 25 years. And we must never forget the impact of HS on a patient's quality of life, which is often significant and may even be life-changing. So that was a quick overview of hidradenitis suppurativa, and I do hope you found it a useful reminder. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.